Triage accuracy hovers at about 60% overall, and only at about a 43% accuracy rate in the ability of distinguishing between an ESI2 versus an ESI3, which is essentially identifying stability and risk for patient decompensation. Accuracy in triage is related to core measures and compliance, and also to appropriate transfer time to the ICU. It is a matter of patient safety and financial stewardship. And for that reason, our episode topic today is fixing triage accuracy to reduce risk and improve patient outcomes. My guest has published over 100 peer-reviewed journal articles, 24 of which have been on the topic of triage. One of her articles in 2008, titled Triaging the Emergency Department, Not the Patient, has been cited over 90 times in subsequent publications. She is primary author on a qualitative exploratory study regarding the effect of mandatory triage questions on triage processes. In addition to being director of emergency nursing research at the Emergency Nurses Association, Dr. Lisa Wolf is a fellow in the Academy of Emergency Nursing and also a fellow in the American Academy of Nursing. And with that, let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Lisa, welcome back. It's great to have you back on our podcast.
Thank you.
So you were on an episode about last year, I think it was in October, on structural and implicit bias in nursing practice with Dr. Ana Valdez. But today we're here to talk about triage and to talk about really the implications of triage for the nurse executive. Let's do some level setting first. What is triage?
Okay, so emergency department triage is the way in which nurses assess and make a clinical judgment about acuity, meaning how stable is this patient? Is this patient going to decompensate in the waiting room, essentially? And if the patient is unstable, then they facilitate rooming. If they are stable, then we consider how many resources will this patient need to get to a disposition. And that can track where the patient goes. Do they need to go to the main department? Can they go to a fast track or an urgent care area? So it allows you to stream your patients in a way that theoretically doesn't overburden any particular area of the emergency department, which means that people get appropriate care and resources in a timely way.
What's interesting, I heard you not use the word is room. So a triage is not a room.
No, triage is a process.
Interesting. And how is triage predominantly done in the United States, and does it vary across the world?
Most places worldwide have moved to a 5-tier system, right? So it gives you your emergent, your critical, right, or resuscitative, life-saving interventions, emergent, kind of stable, but requiring a lot of resources, and then more minor care, right? So 1 through 5, 1 usually being the most acute, 5 being the least acute. So most places, there's a bunch of different triage systems that are validated in their particular areas. The one that's used in 94% of emergency departments in the United States is the Emergency Severity Index, or the ESI. Canadians use the CTAS, the Canadian Triage and Acuity Scale. Manchester triage system is used a lot in the UK and in Europe. There's a South African triage scale. There's a Korean triage scale.
But they're all 5 level.
They're all 5 level, and they all reflect there are subtle differences that reflect the priorities of those particular medical cultures.
Okay. But the reason that we're here talking today, though, is it sounds like we've got some significant quality issues that are going on out in triage. Fairly widely published
Yep.
that in most hospitals, under the best of circumstances, triage accuracy is no better than 60%. Why are we so bad at it?
Oh, let me talk about that. That's why I have a career. So I've been studying triage since 2005. And so the first sort of little background, the first kind of work that I did began as I was like a house supervisor, a house educator. And so I'm seeing people being admitted to the ICU from emergency department hallways or fast track. And I'm like, why is this happening? And then back to that initial judgment of acuity, right? That triage decision is the most important, potentially, decision that can be made for a patient because that initial clinical judgment, that triage acuity decision determines how fast we want to see that patient. Although time is not part of ESI, like the urgency with which we want to see that patient, the amount of resources, right? All of that. And it sets this expectation for stability, right? So the communication piece of around triage is a common language of acuity. So if I say to you, Nick, I'm putting an ESI 3 in your section, right? Then what that's shorthand for, here's a patient who's going to need a workup, but they're stable. Get to it as soon as you can, but not emergently. That's how that conversation is translated. Now, given that, the reason that we are so bad at triage is several reasons. One is we don't know the ED population is essentially unknown, right? These are not people we're familiar with for the most part. So we don't know their baseline. And the second piece is that they're potentially acutely ill. What people tend to do is assume that this is just a measure of sorting, right? If this, then that. And triage is actually a much more nuanced and subtle process of clinical judgment that actually takes a lot of education and a lot of experience and a lot of training, right? People who were, and this is why, if you think about what is different about emergency nursing, we deal with symptoms, not diagnoses. So if you're a medical surgical nurse, you can be expected if your patient has congestive heart failure, right? You understand that's a medical diagnosis out of which all kinds of interventions and assessments flow, right? But you know that patient has congestive heart failure. What we get in the triage place or the beginning of the triage process is this is a patient who can't breathe. This patient feels short of breath. There's about 15 different things, all of which are bad, that can cause someone to be short of breath, and a bunch of things that aren't as bad. And so the experience and the education and the training to discern which of those causative things requires your patient to be seen immediately and those which can help them wait is a bigger process than if this, then that.
Are there structural reasons also or policy reasons that some organizations may put things in place that hinder triage effectiveness? And what does
Yeah.
that look like?
So if we think about this process as like almost an expanding circle of rings, right? The middle is the individual nurse. What do they know? How much experience and education do they have? How able are they to apply that knowledge to a unique patient situation? That's the center of the process. The next ring is what is the unit expectation for triage? And that outer ring of that is what is the administration expectation, right? So that middle ring is things like, is anybody an ESI 2? So structurally speaking, if you set up your triage process to start with like someone who's not a nurse evaluating the patient first, right? So a greeter, a first eyes, a registration person, right? Like I talk to a lot of people at a lot of hospitals across the country, and that's actually pretty not uncommon, right? That like some person who's not a nurse is maybe collecting a complaint, or one nurse is trying to eyeball the entire waiting room to see who's sick and who's not. And I would argue that really delays the identification of people who look okay, but who are not. So those types of two-tier or first look processes are not recommended for that very reason. Other pieces, other structural elements that we need to think about is the prevalence of crowding and boarding in the department. If that limits your emergency department beds, the pressure to not bring people back immediately becomes really strong. And so if I'm a triage nurse and I have a patient who's really should be a 2, but I don't have any beds. And my nurse manager tells me, you can't leave an ESI 2 in the waiting room. That's not allowed. That's against policy. The pressure on me now, as the person making that clinical judgment, is to explain away maybe that tachycardia and make them an ESI 3 so that they can wait in the waiting room, but it doesn't make them any less sick. It just creates a paper patient that is on paper okay, but who is really not, right? So those kinds of pressures become really a problem.
So for the manager or the director of the emergency department, or even a quality nurse, a nurse that's working in quality, or even a CNO that's listening, what should those policies, in your opinion, look like so that that pressure is, I guess, should that be in the policy? And if not, what should the policy look like so the pressure is not imposed on that triage nurse?
Yeah, it's a really good question. And I think that because it's a structural problem, it's not as simple as, well, triage them correctly, because which is step one, of course, obviously, triage people at the acuity level that they actually are, not the one you need them to be. But I think that there needs to be, and this goes really to charge nurse training, right? Which is a separate issue, but related in the sense that the charge nurse is responsible for the flow. And there are charge nurses who are like, nope, sorry, my beds are all full. You can't bring any back. And there are charge nurses who are like, okay, this patient is about to be discharged. So let's pull them out and put them in a chair over here while they're waiting for their ride so that we can bring this sick patient in. So a flexibility of movement, right? Care doesn't have to take place in one place. And in an emergency department where you have unpredictable flow of both volume and acuity, you have to make the people working inside the main department understand that a patient who's not on a monitor and not receiving like active IV therapy or pulmonary therapy can be pulled to a less acute space, freeing up that spot for somebody who needs it. And that also speaks the need for a better outflow process. I think I would recommend to any nurse executive listening is it's really important to collect some data on where your delays are, right? Because we all know that in an environment of less than ideal staffing, the discharge, the decision to the actual exit from the department can be really long. And what that means is for that hour while your nurse is unable to discharge that patient, your bed is full. So there's issues on the front end and also on the back end that facilitate accurate triage. If I know that my colleagues will free up a bed for a patient who's sick, I'm going to triage them more aggressively, accurately than if I know that my poor patient's going to sit in the waiting room forever.
Let's take a step back for a moment. We talked earlier that improper triage may be, or inaccurate triage may be as high as 60%. It's obvious that the implications for that is that it would yield to poor patient outcomes, but can we explore that a little bit further? What type of poor patient outcomes would we expect, or what impact does it also have on the department as a whole when you've got improper triage?
I've done a couple of studies about this. One I did about 12 years ago now with a student of mine, and we looked at delays to the ICU, right? So there was the 4 hours up or out rule. And so we were trying to figure out like, where's the delay? And everybody was focusing on the transfer piece. And what we found out through a chart review and a logistical regression analysis, what we found was the problem was actually the patients were under triaged. So these were septic patients triaged as ESI 3s for the most part. That was the largest group. Older people with sepsis triaged as ESI 3s. And so nobody looked for them to decompensate until, boom, they had to go to the ICU, right? So there was a big delay there because those patients were not properly identified at triage. A second study that is actually in final revision that I'm really excited about is a paper that's going to be published in the Journal of Nursing Care Quality that looks at triage as a measure of quality, as a quality indicator. And so what we did was we did a correlational analysis between accuracy and triage in the over 65 population. So triage is an ESI 1 or 2, and adherence to core measures, including mortality and return visits. And we found a very direct, very strong positive correlation between accurate triage and core measures and compliance with core measures and mortality. So what that tells us is that even down the road, because these people are discharged from the hospital, right? So this was their whole visit. The accuracy of that very first decision as the patient enters the healthcare system has a really profound effect on their care trajectory, right? So there's a really compelling reason that we should put focus and effort on training triage nurses really well because they identify sepsis. They get people to core measures. Everybody talks about these we have this bundle, we have this protocol, we have all this stuff, but it doesn't matter in the emergency department if nobody identifies the patient properly. And the person who identifies the patient properly is the triage nurse. So that has to be your best trained nurse. Like the triage nurse and the charge nurse have to be your absolute superstar, most amazing nurses because they're the ones who are going to really determine the trajectory of care for your patients. So we know that in terms of identifying the patients who require time-sensitive interventions, right? Triage is absolutely a critical piece of that decision. We also know that there's a thing called diagnostic momentum. So there's a bunch of studies that I've been reading lately about that anchoring that not just other nurses, but everybody who reads a triage note. If a triage nurse describes a situation, then often the next providers or staff who encounter that patient will not look for anything different. Right. So in other words, if I identify a patient as having gastroenteritis in triage, patient nausea, vomiting, diarrhea, diffuse stomach pain, but if I don't properly interpret what those symptoms actually mean, then the next 6 people who see that patient are not going to be looking for the mesenteric artery ischemia. They're just going to try to control the patient's abdominal pain. Does that make sense?
Yeah.
If I tell you this is what's wrong with the patient, hi, Nick, I'm putting a patient in. There are 3, they've had bronchitis for 2 weeks. Their chest pain is clearly pulmonary. It's not cardiac. How fast are you going to go do an EKG? How fast are you going to draw that patient's blood? Because I just told you in my clinical judgment, that patient is stable and they are not part of a time-sensitive protocol.
Yeah.
You'll eventually get there. But if I'm new or if I haven't ever seen this before, or right, there's a lady, she's 65, she's vomiting, she's got some nausea, some fatigue, it's the flu, don't worry about it, whatever. And she's actually having a pretty big MI, right? So it's that, and this is why the training and education of triage nurses is so critically important because it is a clinical judgment, not a sorting decision. It's emergency nursing in its entirety in a 3-minute time period.
How long should triage take?
It depends. I think, and so this is a study that we've just done about what we call like the impact of regulatory type questions.
That's where I was going with this.
Exactly. So we just published this study in the Journal of Emergency Nursing, and like phase 1 was asking nurses in focus groups kind of what are the questions that are being mandated at the triage encounter and what's the impact of that? And so what we find is that the more questions that you have in that first triage encounter that do not relate to stability, right? The longer triage takes, first of all, just because you have to ask those questions. But we find that those regulatory questions are just like smooshed up in the front together. So what nurses told us was like, I'm asking the patient, like, when was your last period? And also, do you have an advance directive? Kind of like in that order, which is really acontextual. It doesn't make sense to the patient. I don't know how to ask those questions because it's not part of the flow of an assessment. And we see that there are real fidelity issues also when you put a hard stop in a question that the nurse perceives as irrelevant to the stability of the patient, right? So the purpose of the initial encounter is to determine, is this patient dying? Yes or no? Is this patient unstable? Yes or no? Right? That's really the point. And after that, the follow-up question is this patient going to need a pretty big workup to get to a disposition? Yes or no? If no, fast track. If yes, main department, right? So any other questions that pull away from answering those 3 or 4 questions are perceived as either completely irrelevant, right? Do I need to ask you about your smoking history if you're here for a skateboard accident? I do not, right? It has literally no impact on my triage decision. I could ask you that down the road, right? I could ask you that during care. I could ask you that before you're discharged because you may need resources, right? That I can provide to you. So what comes out of that study is this idea that those regulatory questions can be important and necessary, but they can also be moved farther down in the care trajectory, in the care encounter, to places where they are more appropriate. There are questions, things about intimate partner violence or child abuse or elder abuse, where you really need to have a therapeutic rapport with your patient to get an honest answer, right?
And you can't do
Um,
that when you're there for 2 or 3 minutes in a triage chair.
exactly. Or if you're there for 5 minutes and I still don't know what's wrong with you because I've had to go through these 10 questions that are hard stops that I can't actually get to my assessments until I answer. So for nurse executives, you really want to think about the ideas. I need to ask these questions. So let's just put them up in triage because everybody gets triaged. Okay, that's fair, but you're not going to get the result that you want, either in terms of patient outcome, right? Because you lose the thread of like, why is this patient here if you're not careful? So that's actually what really comes out of that study. It's just been published like this week, actually, in the Journal of Emergency Nursing.
How do I know what the triage situation is in my emergency department from a quality perspective? What should I be looking at? Let's assume I have no knowledge or limited knowledge of the emergency department. I was an ICU nurse before I became CNO, or I was an orthopedics nurse before I became CNO. How do I know that I've got a good quality triage program in my emergency department?
Yeah, this is a bit of a mixed methods investigation, right? So the first thing you want to do is ask people, right? Ask the charge nurses, ask the physicians, ask the advanced practice providers, ask the other nurses, right? Are we doing triage well? Or because the nurses in the back, in the main department, or the physicians or the charge nurses, they'll all be like, yeah, like basically I'm getting what I think I'm getting, right? Or when nurse X is out there, like they're sending me train wrecks, or conversely, they're sending me patients that don't need to be here in the main department. So you can look at that. You can look at your core measures compliance. I think we can say, especially for heart failure and acute MI, what does your sepsis compliance look like? Because we know that triage affects those things, right? What is and then I would say go to your educator in the emergency department and ask them to do a chart review. Get your ESI handbook, new version 5, just hot off the presses, and then take a sampling, right? Over the course of 4 weeks, take 30 charts a week and look at the accuracy of that triage as up against the handbook, right? It's not okay to retrospectively make a judgment about the accuracy of the triage decision based on disposition because people change, right? And so what the triage decision tells us is at the moment that patient presented in front of us, what did they look like? What was their acuity? What were their resource needs? That's the only thing that you can judge, not like they crumped 6 hours later, right? Necessarily. Other things that you can look at is if there are any DPH investigations, right? If the reason that we knew in a hospital I worked at about 15 years ago that all was not well in triage was that DPH came visiting and was like, hey, your stroke identification is terrible. So you can look at different types of presentations and see like where your nurse is doing well and where are they struggling.
A lot of times, things that rise to the level of the CNO's attention is when you have a negative patient event.
Right.
I have a patient that had a negative patient outcome because they were mistriaged, and a reactionary event is to identify what happened in that case and then apply it to everyone,
Everything.
as opposed to understand whether you really got a larger problem here or not. Can you talk a little bit more about that?
Yeah. Triage is also very much like we talked about at the very beginning. It's got individual components, but it also has cultural and structural components. Looking at looking at those things, right? So was this a problem? So you have a negative patient outcome, right? let's say a patient was under triaged, sent back to the waiting room, and then proceeded to code or die in the waiting room, right? So they've been through a triage process. So you want to look at what did they look like at triage, right? Like literally look at the vital signs, look at the presentation, look at the triage note. Was this a problem where the triage nurse did not appropriately identify an unstable patient? If so, you take that nurse and you educate them, right? Here's your problem. Here's what you missed. Now we're going to sit down and we're going to go over this, right? If this happens more than once with several nurses, now you have a group problem. Now you have, maybe your nurses are all brand new. Maybe your nurse, what the ENA says for triage standard is 1 to 2 years and all your certifications. So you need to have taken a course in trauma, in peds, in be certified as an emergency nurse, right? So that level, that depth and breadth of knowledge is really ideal, right? So maybe you are like everybody else have just hired a whole bunch of new grads last year, and now they're coming up on their year anniversary in your department, and it's like time to go out to triage. So you want to see, is that a problem? Is it a problem where you have maybe a large contingent of travelers, right? Are travelers making these mistakes because they don't understand the patient population that they're dealing with, right? That can happen too. So you want to really get a good sense of what caused this error. Was this one of those errors where the nurse under triaged the patient because there's no room in the back? Or because, let's say, worst case scenario, it was a kid that seemed okay, but the physician in fast track doesn't like to see kids. So the patient needed to be up triaged to a 3.
Is that appropriate?
No.
Just make
Right.
it
Yeah,
clear
no,
for
no.
everybody.
So what we know is that the way that nurses generally triage, if they're triaging the department, is they triage based on who's in the waiting room and what providers are in the back.
Absolutely.
So Dr. Mike doesn't like kids. So no matter how benign the kid is, I have to send them to the main department. Or similarly, there's no room in the back. So I have to either send sick people to fast track because that's where they can get seen. So I have to down triage them. And so they can wait. Right. So there's a lot of these really weird structural decisions that that triage nurses make almost unconsciously within the cultural structures of their department and their expectations that you may also need to unpack and uncover.
Which is completely not aligned with ESI in any way, shape, or form. There's no question there about
exactly
is
right. So when
Dr. Mike
people are
working.
like,
Yeah.
right. So when people are like, well, ESI isn't effective. No. ESI is actually a really good algorithm. It's the application of the algorithm due to individual unit and administrative factors that make this a problem. Other things that become structurally is if you've got a waiting room full of people and you have a policy that nurses can't initiate care protocols, nothing can be done until a physician sees the patient. Then you better put somebody out in the waiting room rounding and taking and ordering stuff, because those patients who if you have a room full of 3s, if you start lab work on all of them, you can figure out who actually can go home and who needs to come in right away because, oh my God, they look fine, but their potassium's 1.8. That gives you really good information. So if you are a nurse executive in a hospital that does not allow for nurse initiated protocols, I think you might want to rethink that a little bit.
It's interesting. You said earlier it's our application of triage. So just to be clear here, ESI is not the problem. We're terrible at compliance, but the problem is not the tool. The problem is, for whatever reason, which may vary from one site to another or one person to another, we're not properly using the tool.
So I give you the example of the pregnant person, right? Pregnant patient comes in to the emergency department. I have just done in the last 3 years, 2 studies that show really clearly that emergency nurses have no OB information. They have no OB education. They have no training. Any education that is provided in the emergency department is reactive and incident specific. We missed this, so now we're going to ask everyone if they've had a baby within 42 days. Why are we doing that? I don't
Postpartum
know. That's
preeclampsia.
just a
That's the
new
reason
thing.
why.
Right? Yeah, exactly. So that's a big issue, right? So now I give you the situation in the United States where there are a huge number of states, I think 20 states now with abortion bans. So you're going to get, and obstetric deserts, combine that with OB units closing all over the country, right? So either because obstetricians are leaving because of the medical legal climate or because they can't get them to train in residency or whatever. In any case, there's a lot of hospitals that have no OB capacity. And you've got, so all of the OB care in the area, the catchment area, like for hundreds of miles, is coming to your ED. And now you've got a whole bunch of nurses who can't recognize preeclampsia because that is a blood pressure of 140 or greater in somebody who's more than 20 weeks pregnant. 140, blood pressure of 140, that's nothing. That's better than my blood pressure. Any emergency nurse will tell you. They will not identify it as an ESI2, like really emergent thing. So that's one area that's going to be really problematic because there's a lot more pregnant people out there and they're all coming to your ER. That lack of education, like understanding perinatal patients as like some weird niche population, it's half of your population. Pregnancy capable people are like literally half of your population. It behooves you to train people in the triage of those patients. Same thing with mental health. As care gets pared down in the community, we all know behavioral health patients come to the emergency department. Emergency nurses get no education in behavioral health. So those are very specific patient populations that get under triaged all the time with really bad outcomes.
You've used the word education a lot in our conversation so far today, but there's a lot of inexperienced nurses also that are coming into the specialty of emergency nursing. If you're trying to weigh the two of those, is there a value of one over the other, education versus experience?
What I found in my own dissertation study was that education actually is better than experience.
Talk more. Yeah, talk more about that.
So what I found, and this is my dissertation study I did in 2011, right? So what I looked at really was the intersection of clinical decision making and moral decision making. But as part of that, what I find is that what the study found was that people who reason on a social justice kind of level, like their entire ethos about their practice is, I'm here for my patients, not I'm here because I need a vacation or I need to pay for a vacation or my college tuition or my kid's refrigerator for my house. For people for whom this is really an ethical endeavor, they make better clinical decisions. Why? Because they ask better questions, right? They are compelled to ask better questions. The second piece that we found is that baccalaureate prepared nurses on entry made better clinical triage decisions. And I think part of that is because with a baccalaureate education, you get a lot of social sciences education. And so there are different perspectives, different ways to ask questions, different understandings of cultural situatedness that is not present in associate degree education. The other huge piece is that if you have a bachelor's degree, you have taken a patho course. You've taken a pathophysiology course. And if you don't have a pathophysiology course, you cannot predict what's going to happen to your patient. You are flying blind, right? If you don't have patho and you don't have form, you have no way of understanding what the normal course of this condition is,
Uh,
right?
we have registered nurses that haven't had patho and farm.
Every associate degree nurse has never taken a patho. I teach DNP students advanced patho, and 80% of them have never had a patho course because they are ADNs, which is a great clinical education. And then they do exactly what we tell them to do, which is do the RN to BSN completion program, but there's no patho anywhere along there. And so for me, the biggest change in nursing education or clinical education is a mandatory patho course. And people are like, oh yeah, it's included, but it's not. There's no focus on that, right? So if I have a patient coming in with a complaint of shortness of breath, right? I have to know in my head, okay, what causes shortness of breath? Is it a gas exchange problem? Does the patient have pneumonia or CHF or atelectasis or an empyema? Is this a neurologic problem? Are they having an overdose? Is there a brainstem problem? Is this a GI problem? Are they in late stage pregnancy? Do they have ascites, which is causing their diaphragm to not be able to drop, right? So there's all these things, or is it a cardiac problem? Are they anemic, right? Which can also cause shortness of breath. So understanding multiple etiologies for a presenting symptom you got to have a patho course.
Yeah. Huh. So,
If I were a nurse executive, that's the thing I would require on hire into the emergency department. You must have taken a full semester of pathophysiology.
yeah, one other thing, although our audience for this podcast series is nurse executives, nurse
Right.
leaders, and those aspiring to those roles, but you spend a lot of time on another podcast channel and just want to put a plug out there for a moment in the event that any nurse executive is listening and is looking for alternative ways of education. There's another podcast series that's very clinically focused that you're on that really talks about triage in nearly every episode to some extent called,
Yep.
let me make sure I get this right, How Not to Kill Your Patient. Can you talk a
Yep.
little bit more about that?
Yeah. And so that's a podcast that Kevin McFarland and I came up with because we're both educators and we're like, how do we get like these newer nurses up to speed? And so we came up with this idea for some of them actually are a little bit longer than we had planned because we talk a lot. But the idea was a clinically focused, how do you assess? How do you identify the bad thing? How do you do immediate treatment? And what happens next? Right? That's the focus of it. So we talk about like triage specifically, but then we thought we'd go through our review of systems, right? So we talk about neuro problems and cardiac problems and pulmonary problems and GI, OB, behavioral health. We go through the gamut in terms of what do people present with? What does it mean? What do you do about it? Like, how do you know whether it's this thing or that thing? Yeah. In terms of
Free education.
free education, and it's fun. It's funny. No PowerPoints involved. Yeah. So that I think is a good place to start. Again, it's combined 40 or 50 years of experience, but I think it's useful. My students like it. They have to like it. They're my students. Other people are like, oh, hey, I really like that podcast.
Lisa, thank you so much for your time today. Do you have any closing thoughts as we wrap up this episode, like some key takeaways?
Yeah, I think the big thing to consider if you're a nurse executive is understanding that again, this is possibly the most important decision that is made for a patient as they enter your healthcare system, as they enter your hospital. It determines appropriate acuity, it determines what people are looking for, it determines really care outcomes to a certain extent. And it also can put your hospital in a really great place, risk wise, risk management wise, or really challenging place, risk management wise. So it really is worth the time to go and investigate what is happening down in your emergency department triage because it affects everything else that happens in the hospital.
Fixing triage accuracy to reduce risk and improve patient outcomes was our episode topic. Lisa Wolf, the incomparable Dr. Lisa Wolf. Thank you so much for joining us today.
You're welcome. It was really fun.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.